Welcome to the Birth Lounge podcast, an empowering space for expecting and new parents to hear candid conversations with experts to learn how to craft their ideal birth. You've got scary questions that you want to stop Googling, and we've got evidence-based answers with data to back it all up. Hey y'all, and welcome back to another episode of the Birth Lounge podcast. Today I'm so excited to have my friend Nurse Beckie on. You can find her on Instagram at Nurse Beckie. She is a registered nurse. She's an IBCLC. She's going to be a midwife really soon. And today we're talking about trauma-informed breastfeeding support in the hospital. Now this, if you're pregnant, you've never had a baby, you're probably like, what the heck? Why do we want to talk about this? And if you have had a baby, you're probably like, wow, I wish I had this conversation before I had my last baby. For those of you who don't know, sometimes, a lot of times, many times in the hospital, lactation support can be kind of spotty. Sometimes it's a little aggressive. Very few times is it actually trauma informed. And for me, this is a lot of places where new parents find themselves kind of questioning themselves, feeling like they're not having a lot of support, and or the support that they do get, it makes them feel really bad about themselves, their milk supply, their baby, just them as a parent. And so I wanted to have Nurse Beckie on the show today to talk about what can we do before your baby gets here to kind of set you up for good, solid breastfeeding support in the hospital, and B, if you find yourself in a place where you have support that maybe is not aligned to you, what options do you have? What kind of control do you have? How can you get yourself out of that situation and get some good, solid breastfeeding support in there? So, Beckie, welcome to the show. Please,
thank you so much.
take it away. I'm so excited to hear everything in your brain,
Yes.
and to know that people are like really dying for this information, because this is a hard place to find yourself right after you have a baby.
Yeah, absolutely. I have so much to say. I'll try to keep my thoughts organized because, I'm very I have so much to say. Anyways, I think the first things first, when you become pregnant, I think it's really important that it's easy to just fall into the trap of just listening to your provider and just kind of doing whatever they say. But I think we have to put the power in our hands and engage in our pregnancy as you're preparing for birth, setting yourself up for success. And I could go into the barriers and, the financial barriers, the location barriers of how that can be really difficult. But the beauty of the internet is there's a lot of free information out there. But I really want to empower people who are pregnant and preparing for birth, or, even same-sex couples and, people that are using surrogate or adoption, to really look into their options as far as feeding their babies, because there are lots of options, even if you aren't the carrier of that baby, to even lactate. So that's another topic for another day. But yes, putting the power into our hands as far as doing our own research, what lactation consultants in your area that you can utilize, what information that you can learn about prior to giving birth. And that's as simple as learning about what colostrum is, which is the first milk that your body starts making whenever you're 16 weeks pregnant. And the importance of colostrum, the importance of skin to skin, at least for an hour immediately after birth, and not allowing, as long as baby's stable, getting the baby taken from you to do the weight and the vitamin K and the erythromycin, whatever you choose your child to have, really getting that golden hour, which we call it, of skin to skin, allowing that baby to breast crawl. And hand expression, I am obsessed with hand expression. It's kind of weird that I love hand expression, but I love hand expression. I could talk about hand expression for probably 2 weeks. I could do an entire 3-credit college course on hand expression, I'm sure. But you could do hand expression and while you're still pregnant, if you're dying, as long as you are low risk and have no issues and you're over 38 weeks, I tell every pregnant person to start hand expressing. It's a great way to have your body start having some Braxton Hicks, some practice contractions with that oxytocin coming from your nipples and the nipple stem. And then you can save that colostrum. You can, get some syringes off the internet, off of Amazon, or getting those little Haka, little colostrum collectors, and start collecting colostrum while you're still pregnant. So if there are any feeding issues, you do not have to run to formula. You can literally say, hey, I have this bag of colostrum I collected when I was still pregnant. Can you keep this in the fridge or keep this in the freezer? That if you're in the hospital, or even if you're at home, you can just keep it in the fridge or freezer and pop it out, warm it up in a mug of hot water, or if they have a bottle warmer, and then give it to your baby. So there's so much information that you can utilize and education that you can, have prior to giving birth to help, breastfeeding work and chest feeding and pumping, whatever you choose to do for your baby.
I have a quick
So
question before we
yeah,
move on.
yeah.
What if you run into the issue where your hospital says something about they're not going to allow you to give your baby colostrum, or that they really advise you to give formula over colostrum? It doesn't happen often, but we have had a handful of people run into providers who have, in my mind, that's misinformation.
Absolutely. Yeah. So I'll have to send you the study. There's a study that just came out, I would say within the year, that talks about the metabolic effects of giving formula. And, the biggest, I would say in my experience, the biggest reason that formula supplementation is needed is because of low blood sugar in a baby, for whatever reason. If they're small, they're over 4 kilograms, their parent had gestational diabetes, whatever. And then we run to formula if skin to skin and the baby's like the latching is happening, but this, the blood sugar isn't coming up or what have you. But actually, the more formula we give, the higher the spike of the blood sugar, and then the more at risk of like them. It's basically like a sugar high and then they drop, a sugar high and then they drop. And then the body starts having this like metabolic need for more sugar, right? So if we can introduce expressed milk, expressed colostrum sooner, that's going to stabilize blood sugars and then not allow this to happen, right? The up and the down. So I think that's so important, is like having providers that are informed. And at the end of the day, like, even though it's really freaking scary, like, you're the parent, you can say like, no, I've done my research. I have colostrum, I have expressed milk. I want to give that to my baby. And then, I don't want to be sitting here saying like formula is bad, because formula was invented to save babies that weren't able to be fed by their parents.
Definitely.
But we have like resources to use prior to getting that far. But if a parent doesn't have expressible colostrum, the baby has a severe low blood sugar that's requiring supplementation, then that gets to the point of like, I wish everyone had access to donor milk, because that is so important. I understand that donor milk is mostly in the NICU because, those are more sick babies and they're more at risk. But even full-term babies that just need a little bit of help, they deserve donor milk too. Yeah. And so I could preach to the choir about that. But of course, there is always a purpose of formula if it's needed, but there are like 1 through 4 steps, A through D steps that we can take to, really promote using our own milk or human milk prior to that step. So I just think it's scary. I know it can be scary because it'd be very intimidating. And then like nurses and doctors and providers in general can just be like, they can instill fear and practice with fear to the parents. So I think it's just important to even having that conversation with the team. If a person is gestational diabetic or they feel like their baby is measuring big, like, hey, I know my baby's probably going to have blood sugars taken. This is my plan. These are my thoughts prior to even delivering, prior to even having your baby. So I think it's just like having those, like a game plan with your team. Yeah. And also if you have a team that's not going to listen to you, like, you need to find another team.
I agree with that 100%. And ACOG even does state that the parent has the right to disagree with their provider and choose something that's different than what your provider is suggesting to you, even if it puts you or your baby at harm, which no parent would ever want that. Right. But I think it's really comforting to know that ACOG supports you making your own decision, regardless of what your medical professionals are providing to you, because you are the parent. So yes, it's scary, but that is your radical responsibility of being that baby's parent, is you get to choose what feels most aligned to you.
I think it comes down to like a patient-centered shared decision-making approach. So like, rather than having, whatever you say, doctor, whatever you say, like, I'll do whatever you say. It's more like, okay, no, these are the benefits and these are the risks of whatever we're talking about. And like, I want you as the patient, as the parent, to then talk to me about what you're thinking. Like, what do you feel like is right for you or your child or whatever? And then we want to make sure that everyone's safe, of course. But at the end of the day, like, if I'm just telling you what to do as a provider, that patient's probably not going to have much respect for me, because I'm going to just be breathing down their throat and instilling fear rather than actually having a conversation,
Absolutely. And your provider does have an obligation to meet you where you're at. They do have an obligation to help you
Yeah.
find something that appeases them and making them feel safe, that you and your baby are safe,
Hmm.
in helping you
Hmm.
feel that you are choosing the right thing for you and your baby, and then for your baby and making sure that that baby is having all their needs met. It truly is, it's a shared decision making, and I think that a lot of times is lost in the hospital system. So what are some things that we can do, or and maybe there's not anything, but as someone who is birthing in the hospital, are there things that we need to know or bring with us or have in our mind that we can expect and make our hospital stay postpartum a little bit better when it comes to interacting with lactation support?
Yeah. So I think I kind of a couple things I already said, but basically just like doing your own research and like having like a little plan in your head of like what you desire when you give birth, like immediate skin to skin. Really, unless you want to sleep, uh, your baby should be skin to skin. Of course, people get touched out, and then you can, hand the baby off to a partner or a family member, or whatever. But the best thing is to have that baby skin to skin, because the more exposure they get to the chest, the more they're able to just kind of like pick their head up and start rooting, and they're right there. So really like doing your own like research of what you want as a parent, and what you want for your child as far as feeding. And then I think it's important to voice your wants and your desires when you arrive to the hospital, and you might have to say it a couple of times, might be in the labor room, might be in the postpartum room, like really voicing like what you want. Because sometimes, unless we're kind of like, really like prodding and trying to like get things out of our parents, we don't really know like what their goals are. So as a lactation consultant, if I always started off as like, what are your goals? Like, what do you feel like you are wanting as far as feeding your baby? And then it kind of opens up the conversation of, then they feel a little bit more comfortable telling me like what they, in their mind when they were pregnant, or even now, like what they're feeling that they want. So I think just having like a conversation, and creating a space that feels safe to have those conversations, right? um, and I wanted to kind of touch on, I feel like a lot of issues that happen as far as lactation goes, I feel like there's like this micro level and this macro level of issues. So like micro level meaning like a lactation consultant or a nurse is helping a parent and their baby feed, and it might not be going very well. And so I think there's really room for growth as far as like our language and how we interact with patients. And it's not like, like very, I feel like I've found that a lot of people get a little anxious about a feeding and like really wanting it to work, whether it's the parent or even like the nurse or the lactation consultant that's helping them. And so like really taking like a little bit of a calmer approach, and really just kind of like, it's going to be okay. And even if the baby's screaming their head off because they're hungry, like teaching the parent how to calm their baby is so empowering, because then they're going to go home. And if they're never taught how to calm their baby, they're going to be like, what am I doing? I'm not, being a good parent, or like they feel lost. So kind of meeting patients where they're at, just being calm and having good language, asking to touch their chest before you do. I don't really like to touch people's chests. I like, especially hand expression. I'm obsessed, but like I like having them put their hand on their chest, and then I put my hand on top of theirs, things like that.
Mm-hmm.
And then on the macro level, like a systemic level of like, there is a severe shortage of lactation consultants in general in the hospital. 1 to 2 lactation consultants for a 24 to 36 bed unit
Wow.
is not appropriate. Like, so people aren't getting seen. And when they're getting seen, they already are like, in big trouble as far as like having a lot of issues. They're being seen on discharge day, trying to put fires out. And then like the lactation consultants burnt out because they have this compassion fatigue, because they can't give the good care that they can. So they're just like rushing. So then it's like this systemic thing of like, we need funding, we need access for lactation consultants who wish to be lactation consultants to get their clinical hours, to have the money to sit for these exams, which are $800. I had to do a GoFundMe to sit for my exam. I feel like I'm kind of going all over the place. This is the way my brain works, but there's so many layers to the subpar lactation care that some people are getting. And I feel like it depends on the area, depends on the hospital you're in, depends on, honestly, like financially, if people can afford it or not. Like, people that can pay out of pocket are way more likely to be able to get a lactation consultant to come to their home than someone who's on Medicare who it's not covered. And if it is, it's usually in like an office. It's difficult to get to an office when you have a 2-day-old, like there's so many barriers. So I know that was a lot. I'm sorry.
No, not at all. But along those same lines, no, we know that people of color and babies of color fare much better when they are seen by providers of color. Do we see that same kind of correlation when it comes to breastfeeding? Should Black and brown people be having Black and brown lactation providers in order to increase their success?
That's a great question. I don't have a study to be like, hey, here's a study, but anecdotally, absolutely. I think in general, whether you have a, person of color who is your pediatrician, a person of color who's your OBGYN, a person of color who is your hairstylist, a person of color who is your nail tech, a person of color who, like is your lactation consultant. If you look like the person that's caring for you, you're much more likely to relate to one another. You have lived experiences of one another. And I'm not going to assume that everyone has the same lived experiences based on the color of your skin, because I can't do that. Everyone grows up differently, but I can say that I feel like it would be really difficult for a person of color to then just be touched and counseled by someone who doesn't look like them, who doesn't have the same lived experiences with them, or even there's people that don't look like each other, but also are a little bit more woke to what others are going through, or a little bit more empathetic to someone's situation. So I think there's a part of people that look like each other should be cared for by people that look like each other, but sometimes that's not available. But at least the person that's caring for them should at least have an understanding of what they have gone through in their life, at least have an understanding of maybe some barriers that they might go through when they're discharged from the hospital, and how can we really put equity at the forefront of all of our care, whether it's lactation or, OBGYN care or whatever,
Absolutely. And if you find yourself in a situation where you have a provider, lactation nurse, OBGYN, midwife, anybody who doesn't feel aligned to you, and they're certainly not, woke to your lifestyle or your lived experiences or your culture, if it's possible, and I recognize it's not always possible, but if it is, you should be asking for someone different. Don't continue to get care from someone who makes you feel like absolute garbage or makes you feel like you're a bad parent, because you're not.
Yeah, I mean, it's tough because when there's only one lactation consultant for the entire unit, you can't just be like, I want another lactation consultant, because it might not be there. So I think that's the important part of prenatal care, of finding someone that you can talk to prenatally. I literally have friends who are IBCLCs who see people prenatally, and we'll literally do they'll be texting them throughout their postpartum stay, hey, this is what's going on. Sometimes they'll FaceTime them just to kind of check the latch real quick, just out of the kindness of their own heart. It doesn't count as a consult, but that's the importance of having someone that you might have built a rapport with during your pregnancy, that you can confide in even through text or call during your hospital stay, if there is no one else available during your stay, and I think through COVID too, we've gotten to, there's pros and cons to it, but I think people are more apt to go home right at 24 hours once that baby gets their screenings. They can get home as long as everything looks good and they're not having any medical issues. They can get home and maybe, see their lactation support or their doula, or whoever they're able to see in the outpatient world. But I think it's really difficult to your question as far as saying, I want another provider, I want, another lactation consultant. It's who's available? Is there anybody that looks like me that's available? Probably not, which is another topic, the barriers of having someone that, having a team that's diverse, then also it's, me personally, I don't really care whether someone fires a nurse and wants another. There, I feel like there's something deeper. I've heard stories of, this patient fired me, they want another nurse. I'm like, okay, well then what actually happened here? Let's break it down. Let's do a root cause analysis. I don't know. But then that patient's like kind of labeled as like difficult or, and then it's just like, it's this dichotomy of like, do I say something, make myself look difficult? And then there's the resistance from the entire floor of staff members, So it's like, maybe, although I wish everyone had the privilege of saying what's on their mind and firing their nurses, asking for a new one and asking for another lactation consultant, like maybe try to like keep things cool. I don't know if that's the best answer, but but then also like make sure you have like a nice like support system for when you like get out of that place, and like lessons learned. But I think like the most important thing is like trying to prevent any of that from happening,
Yeah,
as
absolutely.
far as, yeah.
Nothing burns my buns more than labeling someone difficult because they're simply advocating for better care or care
you better
that
preach, right?
Like baseline what you should deserve because you're a human in a hospital.
I literally am the nurse that people give me. Like, I am the person that like I'm given the difficult patient and I go in and like, we're cool. Like we're chatting, like we are literally like, laughing and everything's good. I'm just like, I feel, and I come out, I'm like, y'all, like they're just misunderstood. Like you have to meet someone where they're at and have like freaking empathy for people and like meet them where they're at. They might be going through something. Who knows what's going on at home? Like, come on, there's more to it. If someone's actively rude or fires you, there's something bigger. Like you have to like understand it's probably not you. Maybe it is you. Maybe you're being a total B. Like maybe you're not being the best nurse that you can be. And maybe that's because we're so short staffed and running around and we aren't able to give good care to, 3 couplets. We're given 5 couplets. Like when I'm given 5 couplets, I'm literally just being like, hey, you good? Here's your meds. Let me check the vital signs in the baby, make sure any pees, poops, feeds. Okay, I got to go to my next patient. So yeah, like it's so complicated, but
the whole system is just dysfunctional, and that sucks because everyone pays the price, right? Like your doctors and providers do pay the price, your nurses do pay the price, your patients do pay the price, patient experience pays the price, like patient satisfaction, it all pays the price, and it does suck. So you've kind of segued into something I definitely want to hit on in this conversation. We have a lot of providers and nurses that listen to the podcast, watch our YouTube, follow us on Instagram. As a provider, what are some things that nurses, midwives, lactation people, doctors can do to make sure that you are giving trauma-informed care and meeting those patients where they're at?
Yeah. So I'm going to talk about like 2 different things. As far as like being a provider, I feel like we have an opportunity to, if you're a person that like sees patients in the office and then you go to the hospital and then attend deliveries and you catch babies or what have you, I feel like there is so much room for growth as far as like, and I'm not saying that not every provider doesn't create a good rapport, but I think it's so important that we really focus on building these rapports, talking to people about maybe what they've been through in the past. And even on my intakes for like new OB patients, we talk about like any history of abuse or trauma, any, major life stressors, anything that's going on that I should know about that might affect your pregnancy. Like that is so important. And I think, at my clinical experience, I'm given an hour, which I think is awesome, to be with a patient and like really kind of dive into, their life. And then I can kind of make note of certain things that I'm going to revisit every visit that I see them. I'm going to talk to them about whether it is like a social issue, any issues with their partner or like a sick child at home or, financial stressors, what have you. So then you're kind of like building this rapport, you're checking in on them, you actually like, care about what they're going through. And then you can really like have an idea of maybe some things that might be triggering during their birth experience, during their postpartum experience, especially if they have a history of trauma. Like maybe they won't tolerate cervical exams. Maybe we'll not do any cervical exams unless they feel pressure and you get consent and you feel like they're going to deliver.
Right.
Like we have to also visit like is cervical exams necessary?
Yeah.
But I feel like there's so much to talk about that. Okay. So of course, building rapport during pregnancy and really recognizing what patients have been through so that we can really like understand sometimes like their pain response during labor and delivery, how to help them cope, making sure that they have a partner or a support person that is they feel safe with, because sometimes that's not always the truth. Like, and then like, you know, making sure maybe if they have the ability, or we can give them resources to even get a grant or you know, funding for a doula in birth or anything like that, like giving them resources so that they're set up for success. And then during like the labor delivery postpartum period, again, cervical exams, the way you communicate with people, asking for consent, like the just examples of ways that we can, like, don't touch anybody without asking them to touch them, like things like that, that you can just reduce and practice with trauma-informed care. Because there's nothing worse than someone doing a cervical exam on someone and then they're crawling up the bed saying no, and you continue. That is assault, like bottom line. So as providers, we have to take a step back, like, and ask, like, is this cervical exam required to do my job? Not necessarily. Unless that baby's head is coming out, you're going to put sterile gloves on and just catch. Like, it's okay. And it's also okay to, if they consented for a cervical exam and then they say no, you can stop. And then you just say, we're going to take a pause. So that's just an example of like the way that we can practice with trauma-informed care. As lactation, again, asking before touching. I always put my hand on top of someone's hand whenever I'm touching their chest. Sometimes they don't quite they don't quite get the feel of hand expression. So then sometimes I'll say, like, is it okay if I try? And then you can try after me. And then I'll kind of show them the press back and the roll forward to really get a good drop of milk. And, you know, sometimes it can be sensitive. So if they say like, oh, that hurts, I'm stopping right away. Like, do not continue, because sometimes it can be painful to hand express, especially if someone has sensitive nipples. So just some ways to really like think about how to reduce the trauma that we're, like, sometimes we are active participants in people's trauma, and we have to recognize, like, we have to prevent it. And how can we do that? And that's like the most simple way to explain it, is like asking for touching, consent, things like that. But then also, like, I understand, like, we all have to work fast, but like working fast doesn't mean that it's effective. So you might like feel like you're talking really slow, or you're talking like, you know, you're taking forever in a patient's room. But sometimes if you are thorough in 10 minutes versus fast in 5, you won't be called back to the room. Because like, say like they won't, you know, a patient doesn't understand what the provider is saying or whatever, then they might call you back later. But if you can do your job and do it well in 15 minutes of education or whatever, they might be more apt to understand you. But then also just like meeting them with empathy. And it's just so important to meet people where they're at, meet them with empathy. And if you feel like, I don't know, not every provider is like this, but I feel like I have this ability to kind of read the room. And sometimes I feel like, what's going on? And I'm like looking at the partner on the couch, like, oh, did you do something? In my head. But but then like you like kind of make it like not so serious, but you're like, you know, like, okay, what's going on here? Like, how can I help? And really like helping patients, like, and then usually gives them the permission to start bawling their eyes out, and they tell you what's going on. And then you make a plan as far as like whether it's feeding or their pain, or maybe they're having flashbacks from their delivery experience or whatever. And then that's an opportunity to have a conversation and really make a plan with the team of how to then not service recovery, but like make things better, you know?
Yeah.
And then expect things for in the postpartum period. Those things that happen in the hospital or feeding issues are definitely going to be something that doesn't just go away by walking through the threshold of the automatic doors in the lobby. Like, you know, they're going to require follow-up. So yeah.
Yeah, I have two things. So the first is I always, and these are things that Tranquility by Hee practices. So this isn't just, all your listeners, we are not medical, but these are things that we do to inform our trauma informed care. Is the
Mhm.
first thing is I always remind my team to ask yourself, is this a belief or a choice that I think is right for this person and I'm trying to put on them?
Mhm.
Or is this truly our only option going forward? If it's really our only option, we have no other alternatives, which is like so rare. You pretty much always have another option. Then that is, I mean, that's unfortunate. We just have one thing going forward that can get us to your goals. For the most part, there's always almost another alternative. And so that leads me into my second thing, which is just presenting options. Would you like me to show you hand expression and then you do it after me? Or would you like to do it and I talk you through it verbally? Let that parent decide
Yep.
what feels best to them while you're giving them options of ways to achieve their goal. The goal doesn't change. The goal is to hand express. How are we going to achieve that goal? And presenting parents with options is the number one way that you can keep them in control of their own experience. But you, as the provider, as the practitioner, have to be willing to look deep inside of yourself and say, hey, you know what? I don't always know what's best for my clients. And so I'm going to put it in their hands. They can choose what they want, and I'm going to support them going forward in that.
Mm-hmm. Absolutely. And I feel like that is the most important, like, part of being a lactation consultant is like kind of like presenting options on a platter and like letting them choose, And I feel like whether it's hand expression, whether it's if someone has to start pumping, like say they're like, I can't pump every 2 hours. Like, no, you can just pump after every other feeding or whatever, what have you. Like, these are the options that you can do. And then also, like, my biggest thing is parents understand that just like sometimes it's just like feed your baby. Like, I feel like there's a lot of like external factors of like, what time did baby latch? How long were you on? Did you do both sides? Like, it's just like, relax. Like, it's okay. I'm talking about like, like providers like
Yep.
obsessing over the numbers, obsessing over the stimulation and the time and the blah, blah, blah. Like, skin to skin, feed your baby, and like, it's okay. And also, like, it's okay to also be hands off as a provider and allow and empowering a patient to latch their baby. And it's I can't deal with people that just want to like, push on the baby's head and like put them on the breast. Like, I always put my hand on top of a parent's hand and never on the back of their head, on the baby's head, because that's actually opposite. Like, the baby's going to push back onto your head.
Mm-hmm.
So it's an instinct, like, never do that. But like, the shoulders / lower neck. And I'm always on top of a parent's hand. I'm always like, really, or even just telling them what to do, like walking them through. There are some parents that are so fresh that they don't even like know when I'm verbally instructing, like, okay, now, hold the breast with his hand, or like have the baby cradle it in your arm and belly to belly. Sometimes they do not learn by just being told. They don't learn by verbal explanation. So it has to be hands-on, but it's like, we have to like not be rough, like really, focus on physiologic positioning, laid back, skin to skin, belly to belly, things like that can really help parents recreate it at home, but also feel empowered that they can do it. Does that make sense?
Absolutely, it does.
I just feel like, yeah, and it comes back to like how I feel like we're pressured to be fast in these rooms. So then we're going to be just like rough and just get it done, get the baby latched. But like, that's not always like helpful, because I'd rather do it really, really well in one visit. And then they're empowered to then keep latching their baby in that way because they actually grasped how to do it. And then you're least likely to then be called back to that room for latch help. And you can see more patients. Does that make sense? So it's like a win-win. It's like
Yeah,
a win for me because they're actually grasping everything that you're saying. It's a win for them because they're empowered to then really be able to feel like they can do it. And I involve the partner, the family member. I'm like, see, look how they're doing it. This is, I pull back the cheek. This is what the baby's, mouth should look like. This is what the nipple should look like. You really shouldn't see anything. This is, you see the vibration of the breast. That's the baby kind of, really bringing the breast tissue into the mouth and things like that. And like, I have the partner like take a picture. This is the positioning. So when you're home and you're like, wait, how did Beckie have me do it? That's, and you see like the setup, whether I put a pillow underneath their elbow or whatever, it's just helpful to kind of involve also the whole village too, so that everyone feels like they have a part in it.
Totally. Man, this has been so helpful. Okay, my final question to you is about financial support. So, is it true that everyone's insurance does have to cover lactation visits? How often do we find that facilities have free or community-based breastfeeding or nursing support groups, things like that?
Great question. So, I mean, legislatively, yes, all insurance companies are supposed to cover lactation. It is very, very difficult. If anybody that works for insurance companies are listening,
call me.
Y'all need to get it together. For real. I'm over it. I literally have gray hairs. The only reason why I have gray hairs is because of insurance companies. I'm just kidding. But kind of. But yes, I mean, there are certain insurance companies that are fantastic. They cover like 6 to 8 postpartum visits. They cover some prenatal visits. So really, you want to know like what your insurance covers. Granted, I have had patients who will call their insurance company and be like, hey, do you cover lactation? Do you cover breast pumps? And they're like, no, we don't. And realize they actually do, but whoever they're talking to doesn't know, So it's really difficult to actually find the truth. But the biggest, I guess the best thing is to like then find a lactation consultant and see if they cover your insurance, and they will be able to tell you. But as far as resources, depends on your insurance, depends on your location. So, your best bet is to go on ilka.org, search your zip code, and you can find a local lactation consultant. Usually people that are doing like private practice or have an outpatient clinic or anything like that, they will have themselves listed, and you can find someone in your area. A lot of times providers, whoever you get your OBGYN care or your midwifery care with, already has like a list of lactation consultants that they utilize. So totally, tap into that list to actually do a prenatal visit with them, get some, education prior to giving birth. And then you have someone, if you like them or not, or you just want to kind of like shop around, you have someone that you've contacted prior to giving birth and then can call for lactation visits afterwards. If people use WIC, usually some WIC offices have lactation support there. There is an app called Pacify. They cover certain states. They do the audio and video visits. It's an app that people that have Medicaid can use, and it's free. I think there's only certain states, but they can use. But also that's something that you can get a monthly membership and then utilize unlimited as well. I'm trying to think. And then a lot of hospitals have, support groups through the hospital. A lot of like private organizations will have support groups. So it's really like kind of doing your research. I don't have like one good answer, because I think that's also a barrier. It's like, really having the really like the mainstream or like the easiest way to find resources in lactation. But I think that's those are the best like ways to find it, through your provider, ilka.org, different apps on your phone, websites that you can utilize. And then like, the beauty of Instagram and YouTube and stuff is you can do your own, own education as well. So, yeah. And then I would also say we need systemic change as far as like access to lactation care, both on the patient side and also the provider side. I feel like there are so many people that want to be lactation consultants, but it's really difficult to become one, whether it's being able to afford the education. You need like 90 hours of education through a university or like online program. And then you have to find an already established IBCLC to be your preceptor, depending on the pathway. So there's different pathways that you can go through. You need anywhere from 300 to like 1,500 clinical hours, like absolutely outrageous. And then the exam, very expensive. So it's a very valuable, resource, yet it's so hard to obtain. And I think we need more lactation support, because we know that the more people that can give their milk to their babies, it will help improve their own health and their baby's health for years and years to come. And it's generational, so why not invest in it now,
Absolutely. I always think about what would our country look like if we did things the right way. And I feel like I say this at least once a day. Usually it's like 10 or 15 times a day, but one day our country will do the right thing and we will have all these supports set up and parents will really be set up to flourish from kind of day one. Right now, that's not our reality. And I'm really grateful and excited to have people like you in this realm with me and sharing this space on the internet to make sure that these barriers are starting to be crushed and that this access is starting to be much more widely available to everyone who needs it. Beckie,
Absolutely.
Oh my gosh, this was absolutely amazing. This was such a good chat. Thank you so much for being here with me. Now, I told people about your Instagram, Nurse Beckie. Is there anywhere else people can connect with you or things that you offer for lactating people?
Yeah. So I feel like Nurse Beckie is the best place to visit. You can always DM me if you have any questions. I don't give like personal medical advice, but I will be like in like 6 to 8 weeks graduating from graduate school, and then I'll have some time to breathe, and then hopefully revamping my website for lactation and all things OBGYN/midwifery care going forth. So once I can kind of like catch my breath from graduation, stay tuned, everyone.
Oh my gosh, you guys, I hope that you're walking away from this conversation feeling empowered, knowing where that you can find some more resources and feeling prepared to go into the hospital and kind of take control of your breastfeeding and nursing journey. We will see you again next week on the Birth Launch podcast. Until then, take care. Bye, y'all. Thanks for joining us. I'll see you next time on the Birth Launch podcast. Until then, head over to Instagram and find us at Tranquility by Hihi and give us a follow. You can also check us out at thebirthlounge.com.